first question from this is a respiratory. These are respiratory questions, and we'll go through them one by one. Now, these questions may have been provided to you, so I won't go through the detailed explanation, but I will just tell you how to approach, answering these questions, because these are multiple choice questions. Okay. So the first question is, you can all read there that this 33-year-old person has had a road traffic accident and he sustained a fracture of his femur. And then suddenly somebody finds him to be quite short of breath, and the patient appears to be confused, and there is evidence of some petechial hemorrhages. So what has happened here? Okay. Now this is quite, this type of scenarios can appear, when you are working in UK as well. So this is very much similar to sort of a practical scenario. So what do you think is the most likely diagnosis?
Sir, it is a fat embolism. Sir, fat embolism.
Very good.
Embolism is
very good. Very good. Excellent. So this is a fat embolism. So the key thing here to see is why have they provided so much information in this question? Okay. And what is the reason why they provided this information? That is the key thing here to see. Okay, so immediately you can rule out probably three things. Okay, chest infection is ruled out because chest infection, this patient was quite healthy, fit and well, and this has happened after surgery. There is no history of asthma, so this can't be an asthma attack. And of course, if it was a tension pneumothorax, the patient will be very, very ill. Okay, they will be hypotensive, they will be tachycardic. So the only two things that you are left with is option B and option D. Now he's a 33-year-old gentleman with no risk factors for pulmonary embolism. Okay, so you can debate that the pulmonary embolism part can be ruled out, and hence the answer to that question is fat embolism. So that is how you work through the different perspectives. Now you may think that looking at the question, I know the answer, and you will go for one answer, but I would still suggest that you try and see, read the question properly and then look at the options. Okay, so that is the correct answer. So the next question is 72-year-old gentleman with weight loss and dyspnea, and this fellow has been diagnosed with small cell lung cancer. And there are lots of other things that can affect small cell lung cancer in terms of, so what is the one adverse prognostic feature? For this, you will have to look at the textbooks. So again, if this question has come, it is quite possible that they may give you a different option when they frame this question again in the exam. So they will still ask the same thing, which one is an adverse prognostic feature, but they will change the right answer to something else. So what I would suggest is you look at this point when you're reading through your tutorials or when you're reading books, that let us concentrate on all the adverse prognostic features of small cell lung cancer. Now, cavitation on a chest X-ray is not seen with a small cell lung cancer. Does anyone know what cancer can show cavitation on chest X-ray? Which lung cancer? Any idea? So that the cavitation is usually seen with squamous cell lung cancer, okay? Not with small cell lung cancer. Hypertrophic pulmonary arthropathy is a very severe form of clubbing, which you see in patients with advanced lung cancer. And it is not specifically seen in small cell lung cancer, but it can be seen in other lung cancers as well. Hypernatremia does not happen in small cell lung cancer. It is the opposite, which is hyponatremia. Okay, and finger clubbing again can be seen in all types of lung cancer. So you are left with only one option, which is alkaline phosphatase. So even if you don't know the right answer to this question, you could actually see that all the other options have been ruled out. Okay, so alkaline phosphatase being more than 1.5 times the upper limit of normal is a bad prognostic sign. LDH is a bad prognostic sign. Extensive disease is a bad prognostic. So these are the adverse prognostic features. So again, in the exam, they might actually remove alkaline phosphatase and they might put serum sodium. So it is important for you just to remember what are the adverse prognostic signs, and this question might come in the exam, so it is useful to actually know these answers. So the next question is about a 20-year-old with pleural effusion, ascites and ankle swelling. Okay, so the first thing to note here is why have they given a 20-year-old? Okay, a young person, it's a woman, and then they have given this triad of sort of features of pleural effusions, ascites, and ankle swelling. Blood pressure is normal. So in the investigation, you can see that ALT is 19, bilirubin is 18, albumin is low, and the cholesterol is high. So immediately you can think of some of the conditions where you can get increased loss of protein, okay, or proteinuria, and increased cholesterol because of lack of binding of cholesterol to the albumin. So which is the what is the next most appropriate investigation that needs to be done? So you've got 5 options. Clearly pregnancy test, you can rule that out. Again, prothrombin time, I'm not sure. I mean, her LFTs are all normal, so I don't know why you would check a prothrombin time. You can do urinary protein estimation. Serum protein electrophoresis is usually reserved for patients with multiple myeloma. Anti-nuclear antibody, you can check if there is any evidence of autoimmune condition. So you're basically left with these 2 options, and now you'll have to find out what is the right answer. So the correct answer is E. So low serum albumin and high cholesterol suggests nephrotic syndrome. So this is defined as more than 3 grams of proteinuria. So this is basically a question on nephrotic syndrome. And you knew that immediately because you could see that they have given a triad of pleural effusion, ascites, and ankle swelling. So if you look through your modular course, you will see there is a PowerPoint on pleural effusions as well. The pleural effusion can be transudative or exudative, and in this case, it is transudative effusion. And transudative effusions are always associated with all types of failures. So heart failure, liver failure, and renal failure. And one of the most common causes of renal failure, which causes pleural effusions, ascites, and ankle swelling, is nephrotic syndrome. So you would do a urine protein estimation to check if this lady is passing more than 3 grams of protein in the urine, and that would almost invariably clinch the diagnosis. So the next question is about a 20-year-old with pleural effusion, ascites, and ankle swelling. Okay, so the first thing to note here is why have they given a 20-year-old? Okay, a young person, it's a woman, and then they have given this triad of sort of features of pleural effusions, ascites, and ankle swelling. Blood pressure is normal. So in the investigation, you can see that ALT is 19, bilirubin is 18, albumin is low, and the cholesterol is high. So immediately you can think of some of the conditions where you can get increased loss of protein, okay, or proteinuria, and increased cholesterol because of lack of binding of cholesterol to the albumin. So which is the what is the next most appropriate investigation that needs to be done? So you've got 5 options. Clearly pregnancy test, you can rule that out. Again, prothrombin time, I'm not sure. I mean, her LFTs are all normal, so I don't know why you would check a prothrombin time. You can do urinary protein estimation. Serum protein electrophoresis is usually reserved for patients with multiple myeloma. Anti-nuclear antibody, you can check if there is any evidence of autoimmune condition. So you're basically left with these 2 options, and now you'll have to find out what is the right answer. So the correct answer is E. So low serum albumin and high cholesterol suggests nephrotic syndrome. So this is defined as more than 3 grams of proteinuria. So this is basically a question on nephrotic syndrome. And you knew that immediately because you could see that they have given a triad of pleural effusion, ascites, and ankle swelling. So if you look through your modular course, you will see there is a PowerPoint on pleural effusions as well. The pleural effusion can be transudative or exudative, and in this case, it is transudative effusion. And transudative effusions are always associated with all types of failures. So heart failure, liver failure, and renal failure. And one of the most common causes of renal failure, which causes pleural effusions, ascites, and ankle swelling, is nephrotic syndrome. So you would do a urine protein estimation to check if this lady is passing more than 3 grams of protein in the urine, and that would almost invariably clinch the diagnosis. Next question is again on small cell carcinoma, and it is asking you which of the following non-metastatic manifestations is she most likely to develop. Okay, so non-metastatic meaning it is a paraneoplastic syndrome. Okay, so what kind of paraneoplastic syndrome is most commonly seen with small cell carcinoma of the lung? Again, this is, I mean, for respiratory medicine, I would say small cell lung cancer and squamous cell lung cancer are the two most popular cancers on which you will get questions. So definitely, because the reason being that both squamous cell cancer and small cell lung cancer present with paraneoplastic problems. In squamous cell cancer, you will see PTH-related protein secreted causing hypercalcemia. And with small cell lung cancer, you can see things like, Eaton-Lambert syndrome. You can see hyponatremia. You can see SIADH caused by increased excessive ADH secretion from that cancer. Okay, so the right answer would be C, which is the Eaton-Lambert syndrome. So the other way of actually looking at this is rather than using the word non-metastatic, it is basically asking what are the paraneoplastic manifestations of the small cell lung cancer. Okay, and you can see that these are all 5 paraneoplastic manifestations. So again, going back to the question, myasthenia gravis is more related to this acetylcholine receptor antibody problem. HPOA, as we have discussed in the previous question, can occur with all types of cancers. Erythema garatum repens doesn't happen in small cell, and PTH-related peptide is secreted with squamous cell lung cancer. Okay, not with small cell. So you can rule these things out simultaneously. Next question is about rheumatoid arthritis. And again, there will be lots of autoimmune conditions which can be mentioned in your exams, and it is quite popular for the exam, for people who set the questions to actually set questions based on conditions that affect the lungs. So there are lots of autoimmune conditions that affect the lungs. Most commonly you will see questions on rheumatoid arthritis, the drugs that are used in rheumatoid arthritis, and also in scleroderma. So please make sure that you touch base on at least scleroderma and rheumatoid arthritis and its connection with the lungs. Sometimes you will get questions on inflammatory bowel disease as well, which will be connected to the lungs. Okay, so inflammatory bowel disease and lungs can also have questions. So these things are quite popular because they are more theoretical rather than practical. And as you know, part 1 and part 2 both are theoretical sort of exams. So you need to know your theory very well. So she's on long-term therapy to control her disease, and she presents with increasing shortness of breath, and chest X-ray shows bilateral interstitial shadowing. So what does bilateral interstitial shadowing mean? Does anyone know what does bilateral interstitial shadowing mean?
Hello, sir. Lung fibrosis, sir.
Could be.
Very good. Excellent.
Yeah, fibrotic changes.
Okay, so bilateral, sort of interstitial shadowing. So interstitium is what surrounds the pulmonary lobule. So you know that within the lungs, the basic functioning unit of a lung is called the pulmonary lobule. The pulmonary lobule will contain acini, okay, and alveoli. So lots of alveoli will come together to form an acini. But surrounding the lung, the pulmonary lobule, which is the periphery or the border of the pulmonary lobule, is where is the interstitium, which contains lymphatics, which contains pulmonary veins. And it is the interstitium which is actually affected in pulmonary fibrosis. As you all know that there is thickness of the basement membrane which prevents diffusion of oxygen, and that is why patients with pulmonary fibrosis develop hypoxemia, and that is why they are breathless. So interstitial shadowing meaning that there is problem within the interstitium, and that suggests that the patient has now developed pulmonary fibrosis. So which of these drugs can cause pulmonary fibrosis? Again, a very common question in MRCP, very common question. Okay, There is no way you can go wrong with this question. So make sure that you are, you just memorize this question, and learn all the drugs that can affect the lungs. Okay. So if she's got rheumatoid arthritis and she's on long-term therapy, then she's most likely drug which we use in rheumatoid arthritis is methotrexate. Okay. Now, hydroxychloroquine does not affect your lungs. Okay. What does it affect?
It affects the eyes.
Eyes, very good. So it will be affecting the eyes. Infliximab, again, it's a tumor necrosis factor sort of drug, monoclonal antibody. Sorry, it's a monoclonal antibody, and again, we've not seen any evidence of that. Azathioprine, what does that cause? Most
It
commonly,
can cause
azathioprine will cause. Yeah, it can cause neutropenia. But in the MRCP exam, you will see that azathioprine will be mentioned as a cause of pancreatitis.
Okay. Yes.
So azathioprine can cause pancreatitis. Okay. And then you've got penicillamine. So I'm not sure entirely about what it's affecting, that it affects the lungs in any way. So the only option you're left with is methotrexate. Okay. So even if you didn't know the answer to that question, if you knew what all the other drugs cause, then you would have been able to answer that question. That makes sense. Okay. Let's move on. So the next patient is a lady with COPD. And again, COPD is one of the common themes that appear throughout the MRCP exams. Okay, pulmonary fibrosis, COPD, pneumothorax, lung cancer. You cannot afford to get any answers wrong on these 4 topics. You've got to, just make sure that you've gone through your modular course or your MRCP questions or your MCQs, and you must master, the question. Also asthma. You cannot afford to get this wrong, because this is if you're a chest physician, if you're working in general medicine, this is a thing that you see daily. Okay, COPD exacerbations, asthma exacerbations, cancers, okay, pulmonary fibrosis. So make sure that you obviously concentrate quite hard on these topics. So she's got COPD and she wants to visit her friend in Philippines. Her FEV1 is 40%. Her last hospital admission was 5 months ago. So again, this is an important bit of information that they've given you. Why they've mentioned this, that her hospital admission was 5 months ago, which obviously indicates that her disease is more or less stable. She's got kyphoscoliosis. Her oxygen saturation on air is 92%. They performed a hypoxic challenge test and her PO2 is 7.7. What would be the correct advice? Now, this question is testing your knowledge, not of COPD. Okay, so there is a lot of, as you say, footage given to COPD. Oh, her FEV1 is this, and she's not hospital, blah, blah, blah. But there is only one line which is trying to test your knowledge here, and that is hypoxic challenge. Do you know the criteria for hypoxic challenge? Okay, very simple. So you don't have to, they're not testing you on what is COPD, why the FEV1 is low, or what is the diagnosis. They're just testing you on, do you know what is hypoxic challenge test, how it is done, and what is the criteria for it. Okay. So the correct answer here is obviously the first one. So what we say is that if you're doing, when you're trying to check if a person with chronic lung disease, and that could include COPD, bronchiectasis, it could include distal fibrosis as well. Will they be able to, be comfortable or survive an altitude of something like 8,000 feet, which is, I think, the planes fly at. So if you're at that altitude, the air is very thin. And by that it means that the percentage of oxygen in air at an altitude of 8,000 feet, which is where the plane is flying, will be only 15%. So it is 6% lower than what it is on at atmospheric pressure here down at the sea level on Earth. So that is why when these patients undergo a hypoxic challenge test, they are asked to breathe 15% oxygen. Okay, and then after 15 minutes, their PO2 is measured, and that's the criteria. So if the PO2 is greater than 7.4, his oxygen is not required, and then if it is between these numbers, then further needs to be done. So as you can see in this question, the PO2 is 7.7. So if it is more than 7.4, oxygen is not required. So I will again ask if there is any more further clarification that you want to do before I can sign off. Okay, thank you everybody,
Thank
and
you,
bye
sir.
bye.